Hi, everyone. I'm Komal Jhaveri, a breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York. And we're here today to talk about early-stage HER2-positive breast cancer and the recent approval we've had for trastuzumab and deruxtecan in this space. Very happy to be joined by dear colleagues and friends. We have Dr. Sarah Tolaney and Dr. Shanu Modi. You want to just introduce yourselves as well, guys?
No, thanks so much for having me. So I'm Sarah Tolaney. I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston. Looking forward to our discussion today.
Likewise, my name is Shanu Modi. I'm a breast medical oncologist at Memorial Sloan Kettering, a colleague of Komal's, and really excited to talk about the early stage use of T-DXd.
Yes, exactly. So I cannot believe the time is now. Like, it's happening. It already happened. We have the approval. I think just a few weeks ago, we were talking about what will happen to DB11 and what will happen to DB05, but now it's approved. We have T-DXd approved for early stage HER2-positive disease as well. And we got the approval for both DB11, which is a neoadjuvant strategy, and DB05, which is for the residual disease setting, the way we had TDM1 for the Catherine trial. Maybe, Sarah, you could tell us first about, what do you think about the label?
Well, it was exciting to see the approvals, as you noted, and I will say I was also a bit surprised by the label indications because they're a lot broader, actually, than the clinical trials. So, for example, the approval for T-DXd for 4 cycles followed by THP for 12 weeks in the preoperative setting was based on DESTINY-Breast11, and its indication is in stage 2-3 HER2-positive disease, whereas the trial itself, the pre-op DB11 study, was specifically for patients who either had node-positive disease up front or had a T3 or greater tumor. So this is a little bit broader than the trial itself was. And likewise, for the residual disease setting, that indication was based on DESTINY-Breast05. That trial was really designed for patients who either had inoperable tumors at baseline, went on to get pre-op therapy, then had residual disease, or they had residual node positive disease at the time of surgery. So it was a very high-risk patient population, but actually the indication is for any residual disease. So it isn't quite so specific as the DB05 study was.
And do you think that's a good thing? You're happy with this pleasant surprise of this broad label?
Yeah.
How do we think about it?
Yeah, I mean, it was a surprise, right? I would call it a pleasant surprise. I think it does allow clinicians to practice as clinicians and use some of our clinical judgment. I will say, I think the right populations were tested in the early stage T-DXd trials. I mean, there's always a risk benefit and ever more so in early stage curable patients. So I do think they chose the right populations. And although the label is pretty broad for both neo and adjuvant, I think in my approach, I will probably, at least initially, start by really adopting T-DXd as was done in the studies, in the higher risk population. I could see that evolve over time, as we get more comfortable using and monitoring, particularly, that there may be additional populations that would be appropriate.
Yeah, no, thank you both. I think maybe because we have 2 settings that we're thinking about adoption as you were talking. Maybe let's take DB11 as a first example, right? So what were you doing in the neoadjuvant setting? Maybe walk us through that, say 3 months ago. What are you doing today, and how do you anticipate adopting this approval and doing something in the neoadjuvant setting for your patient when it comes to neoadjuvant? So maybe if you want to comment on that, that would be great.
Yeah, so I think for my higher risk preoperative patients, I was mostly using 6 cycles of TCHP, so docetaxel, carboplatin, trastuzumab, pertuzumab, so 18 weeks of pre-op therapy. For the kind of intermediate pre-op patients, so those patients maybe who were T2 and 0, or the really large T1C and 0 patients where you really want to give them pre-op, I was actually just giving 12 weeks of THP therapy. So I was those people who are on edge for pre-op were the people I was giving 12 weeks of THP. So, I think that has been my standard to date. I think thinking about now having the DB11 regimen available, I think I would think about it for those higher risk patients for whom I was triggering the TCHP treatment recommendation. And so I think those node positive patients, for example, the large tumors, those are patients where I would think about T-DXd followed by THP in that setting.
What about you, Shanu?
Yeah, I mean, very similar approach. So as I mentioned, I probably will use it in the higher risk population to begin with. So exactly as you said, like the node positive patients or the really large inoperable tumors. Thankfully, we don't see those too often. If I had to think about a sort of outside of that strict DB11 population, I think the other group of patients I am probably contemplating this in are for those patients who have that heterogeneous kind of HER2 tumor, right? Like the 2+ low fish, where we still, or I should say, I still have thought about using ACTHP in those patients, right? And this would be a perfect, I think, other group of patients who would really probably do well with the T-DXd sequence strategy.
So it's mostly the node positives and the inoperable tumors. Are we thinking about that? And as you said, maybe your intermediate risk or your node negative patients, despite the label, we can think about different ways of adopting this practice. And your practice has been THP for 12 weeks to see what they respond. And then do you take them to surgery? Do you do some kind of imaging or some kind of determination of whether this actually worked, or do you need to do more? How have you been handling that?
That's an excellent question. So, we certainly have data for THP now from several trials, at least good PCR data. So we saw the data from Compass HER2 PCR. I think we're usually seeing PCR rates overall around 40%, but it's the ER negative HER2 positive patients where you can really hit like the 70+% PCR rate sometimes. And it's the ER positive HER2 positive patients where we're more in that 35-ish% PCR rate. So I usually do start off with THP. I will say most of the times I do find people are getting pretty excellent responses because I'm treating smaller cancers, right? I'm not treating the very large tumors, and most of these people actually do very well. We do obtain repeat MRI imaging prior to someone going to surgery. And I think, to maybe your point, I think it now will give us a little bit of an option to potentially escalate in someone where maybe we haven't seen a good response. So maybe I guessed wrong, right? Maybe I thought this patient with a T210 tumor was going to do great on THP, and I start out that way, but turns out they get a repeat MRI and, they haven't had much of a response. That's someone where you could think about potentially escalating now, right? It is kind of the reverse order of DESTINY-Breast11.
That I've heard that a lot, thinking about using the reverse sequence, THP first, T-DXd. I mean, what do you think about that? I'll ask a question.
I personally think it's an exciting strategy because I do think one of the challenges with these kind of blanket approaches, like the whole recipe for the DB11 regimen, all 8 cycles, is not everyone needs all that therapy, right? Yeah. And we're not so good at personalizing therapy based on biology, right? We've just made this determination, right? We said we're going to take our really big cancers and our node positive cancers and give them DB11. But the truth is that some of these really big cancers may do fine with less.
Yes.
And some of the small cancers may need more, right? Yeah. Because it is biologically driven. It isn't all anatomic risk. And I think we need to change our practice, but we just haven't figured out appropriate biomarkers to tailor therapy. I think we're getting close there. There are some really cool assays, HER2-DX, maybe tailoring with ctDNA. Maybe there will be these other things, but right now, nothing is quite ready for prime time. And so I think this idea of being able to tailor based on response is helpful, but I will put a caveat in that MRIs aren't perfect. And so I think we have to be careful because particularly in ER positive disease, they are not such a good predictor of someone having a PCR or not. And so I'm not sure that that alone is going to be adequate, but we certainly have other signs. We know that person who's not having a great clinical response, maybe has had no change on MRI. That's pretty rare in HER2 positive disease, but that's someone I would think about escalating.
So I think great discussion points, great points about where we need more work, right? Like we need better biomarkers. Can we pick the right patient for the right strategy? And certainly we have examples that are in the work, such as HER2-DX, which is more prognostic, but maybe a little bit heading towards a predictive benefit piece, and maybe we'll have more. We had trials like the FORGAIN trial, where we incorporated imaging as well to identify where we could give away. Having said that, I think I was just, thinking about the THP PCRs that we see, 40%, as you said, and in the ER negative tumors can be higher. DB11 did give us the data, with just 4 additional cycles of T-DXd, 80% PCR rates, right? And HR positive, unprecedented 61% as well. Like we definitely did better than what we have ever done before.
In a higher risk population.
In a higher risk patient population, which makes it even more attractive in many ways. Of course, the lower risk one could strategize what we would do, but we don't know how to truly identify the true low risk from a low risk and a high anatomical risk patient population, as we were saying. I do like the idea of just having those 4 cycles of T-DXd and not necessarily trying to tease that out too much or hold back on that T-DXd and achieve those PCR rates that we're getting in DB11. It just seems to me that 4 cycles I can handle, a patient can handle with the T-DXd. That makes it tempting for me. But I'm hearing that we're all going to think about this a little differently, right? Depending on what that patient looks like in front of us, maybe we'll do the THP first and then decide if we want to escalate. I'm thinking more like, okay, I'll just do the 4 and 4 because I'm getting a whole lot.
For everyone? Like if you had a T2 and 0, are you going to give them T-DXd followed by THP?
Right. No, that is a different scenario, right? So I'm talking about where the trial patient population was.
Patient.
Yeah,
Yes.
there I'm not going to think twice. I mean, I think also because we've also recognized, I think, that not all PCRs are the same. Even PCRs that we achieve might not be the same. And if we don't achieve, is not the same. I think both ways, right?
Right.
And so I feel like the 4 cycles makes it attractive somehow.
I mean, I saw DB11 as a win-win.
Yeah.
You know, we were able to, in the whole field, I mean, TCHP really evolved to try and eliminate anthracyclines. So we now have a regimen where we have eliminated anthracyclines without adding a lot of toxicity. So I feel like it's a win-win. It's more efficacious, and there was no increase in toxicity with,
I will
with
say,
the
were you
approach.
surprised? Because I will say I was very surprised by the toxicity of DB11 at how well tolerated it was.
Yeah.
Because even that like 4-ish% ILD rate, only half of it was T-DXd, right? 2%-ish, 2%-ish THP, right?
Right.
So it actually, I will say I was very pleasantly surprised. That being said, you know, it still requires prophylactic antiemetics.
I don't think you can diminish the need for vigilance in monitoring for the lung toxicity. But I think it's a combination of 2 possible reasons. The first is it's only 4 cycles.
Right.
And the second is, you know, we're giving it up front. So to kind of come back to the sequence thing, I do think the fact that there is no prior potential lung toxicity therapy before the T-DXd, that could also play a part in why it was so well tolerated. So, I mean, for me, I feel like in our field, we're really kind of evolving into, are you a PAT-CR person or a salvage therapy person? And I think I'm solidly in the PAT-CR camp. I think it's one of our best prognostic markers, and it really allows us to de-escalate therapy. So, and we're doing that a lot. I mean, we can de-escalate radiation therapy now. And as you know, we might even de-escalate the duration of the antibody therapy in the patients who achieve PAT-CR. So, I think of it as a win-win. I'm certainly excited to use it for those, particularly those higher risk patients.
It's so funny, as you were saying that I'm in the PCR camp, I felt so good about hearing that. I'm like, okay, we're at least aligned in our memorial way of thinking here, because I feel the same way too. I'm like, if I had to choose a camp in some ways, I would not be shy of choosing the DB11 camp. I think the one reason that we're even debating that is because, you know, we have PCR data, and while the EFS is really checking out and directionally in the right direction, we don't have the definitive EFS data. So talking about that and talking about what we would do in our, you know, academic centers like Dana-Farber and Memorial, do you think there might be differences in adoption or execution, or would there be any advice or barriers that you might see, a difference between academic sites and community? Is there something that you think, based on your experience, you could either think about what could be different between community and academic centers, what could they do differently, or some piece of advice that you wanted to give to our physicians who are going to start using this, hopefully?
I mean, I think that's an important question. Thankfully, we've had the experience of using T-DXd in the metastatic setting now for a couple of years. So I'm going to imagine most people have sort of figured out what they will do when ILD potentially shows up, which is probably the most really important thing to be prepared for with using T-DXd. So, you know, who is your pulmonary doctor or colleague and your radiologist that you can confer with? And I think once people sort of have a strategy, that's what I've always said is know how you're going to approach ILD, what you're going to do. And when you're prepared, I don't think there should be any real barrier to adopting T-DXd for our early stage patients. So I don't know if you feel differently. But
maybe, Sarah, any advice or any other comments on top of Shanu's advice for our community doctors, things about what they should be thinking about, what they could be doing, because that's not something they are used to doing in the early stage, right? We did TCHP and we did ACTHP, and monitoring was different, or toxicity profile management was different. So any practical advice that you could give our community?
Well, I think we're not used to doing imaging in the preoperative and adjuvant setting. This is a new ball game.
Yes.
And so I do think that does add a layer of complexity. I think, and we'll certainly talk about the residual disease setting, but I think there it's a little bit more complicated because assessing if something is ILD or not is not so straightforward when someone's had prior radiation.
Absolutely.
And so differing between radiation pneumonitis and T-DXd related interstitial lung disease, you could say, well, maybe something's in-field versus not in-field, and try to make that distinction. And we'll do the best we can, but that is challenging. And the way you manage that is different. So you can treat through grade 1 radiation pneumonitis, but you can't treat through grade 1 T-DXd ILD, right? So, we are going to come up with these problems. I think we already in the metastatic setting, right? Someone has a viral infection. You're like, oh, is this their prior virus that's causing these ground glass changes?
Yes.
Is this really T-DXd? So, this is going to happen all the time. People get colds, things happen, right? And it's going to be hard. And this is the curative population. We don't really like holding therapy. We're not going to want to wait for that ground glass to go away because we get anxious when the tumor's in place, right? So I do think it's going to take a little bit of just getting used to. Again, we've been doing this in the metastatic setting, but I think the bar here is different, and delays to care aren't going to be tolerated so well. So I think we're going to have to see how this.
And what do you think your cadence in your practice will be for the imaging? Would you follow what the trial did or what we did in the metastatic trials? Would you think about that differently from day-to-day practical implementation of this in the early stage?
Well, I think in the adjuvant setting, the guidelines are different. So in the DB05 guidance, for example, you are supposed to get a baseline scan, make sure they don't have ILD at start. But it also depends on the timing of the radiation, because you can give concurrent radiation in T-DXd. If you choose to do that, you do need to get a rebaseline post completion of radiation. And you're supposed to get your initial scan after 6 weeks, and then you can do it every 12 weeks, right? So that is, I'm used to in the metastatic setting, I just time my restaging, every 6 to 9 weeks, and that will count for restaging and for looking for ILD. But here, again, you've got to think about these CT scan timings. And so that radiation does play a role because you got to rebaseline them. So I think you should follow the guidance, though, for what DB05 did.
And what about DB11?
So there, you should be getting scans every 6 weeks in the preoperative setting. And so that follows a little bit more in line with what I'm used to.
Right. And it's 4 doses. So
yes, it's not too much.
It's manageable. It's really manageable.
Although it is interesting because they did do it through THP in the trial, right? And so that is something we're not used to monitoring at all.
Yeah. But I wondered if we were to stick with the sequence, if we would do that in practice as well. Like if we started off with T-DXd, given that we saw the ILD 2% and T-DXd 2% with THP, would we now think about it differently and continue to do that the way the protocol did? Or in real practice, would be just okay with the T-DXd component and manage THP, right? Things to think about. I think we've not thought about that. But those are the kind of things I think we still need to be vigilant about and think about. That's at the very minimum, we would do the T-DXd, which is 4 cycles, so 2 scans, I guess. And then do we want to do 2 additional scans during the THP portion or not, is something that, we could think about as well.
Right.
And apart from that, I think you already pointed out nausea management. We can't forget about that. The most common toxicity. It's 4 cycles, but still something that we want to keep an eye on.
And I thought it was interesting when they presented some of the safety data. That there was a much lower rate of antiemetic use in the T-DXd arm versus ACTHP. So we saw, people using 2 drugs. Really, this is a highly emetogenic therapy. So you really need to use 3 or 4 antiemetics. And I think, again, that's sort of educating the community out there to be really aggressive with antiemetics.
More and more. I think it has been a game changer in the metastatic setting to use the 3-drug and the 4-drug. And I think we cannot forget that, or it needs to be stressed even more for our practitioners.
Early stage patients.
In the early stage patients where we really want to make sure they do okay. All right, why don't we switch gears, talk about DB05 a little bit, and then we'll come back to DB11 because we still need to figure out what are we going to do in the residual disease setting if we gave DB11. So it's not over yet. But let's just take a moment to then acknowledge the label for DB05. How do we think about that label versus the trial? And how do we think about adopting that in our practices today? Who would you choose to give it to? Or who would you choose not to give it to and decide between DB11 and DB5? So Shanu, maybe you can tell us a little bit about that.
Yeah, it's sort of hard to think about them in isolation because I think the high-risk patient that shows up is probably a person I would use neoadjuvant T-DXd with. So I wouldn't hold it to give in the adjuvant setting. And again, I'm in the PathCR camp. So it becomes difficult to think about it outside of that scenario. Look, I think there is still a population of patients that does very well with T-DM1, you know, the minimal residual disease burden type of patient, even with the long-term 7-year follow-up from Catherine, we were getting like 89, 90% DFS at 7 years. That's really impressive. So I think for me, I don't foresee saving T-DXd for an adjuvant population. I'd probably use it up front. So from my perspective, the harder question is, what do you do with residual disease after DB11, right? And you know, I've really thought about that a lot. There was really no prescription in the DB11 trial, so doctors were free to choose however they felt the patient should best be treated. And I still think that stands today. I mean, we have options. We have more chemotherapy. You can use an anthracycline, for example. There is an ADC, another ADC option. There's great endocrine therapy options for the hormone-positive patients. So there are great options already. And then there's DB05. And I think one of the things I've started to come around to, which I didn't really think about a lot, is what is that residual disease earlier? What does that residual disease represent? Is it refractory to T-DXd? Or is it that we gave insufficient T-DXd, right?
Yeah.
And I think, Sarah, you're going to present some really nice data from DB09 about the amount of time a person needs to be on T-DXd to get the full magnitude of the benefit. So I think it's going to require paying attention to how patients do with T-DXd in the neoadjuvant setting.
What are your thoughts? And I'll share mine as well, of course, because I'm sure we're all going to have interesting ways of dealing with this, which really highlights the point that this is going to be an important piece for us to carve out. It's a data-free zone currently, but something that is going to be really important for us to address as a community together. But just, you know, to hear your thoughts, Sarah, how are you going to handle that?
I mean, one, it's really nice to have the flexibility with the label of DB05 that it's not so restrictive.
Right.
That being said, I think to your point, people do very well with TDM1 in an all-comer population. We're not specifically talking about people who've had pre-op T-DXd. So I would say, I think generally speaking, if someone has high-risk residual disease, T-DXd for 14 cycles, I think should be offered. If someone has lower risk residual disease, I would still be using TDM1. I think, again, we've seen outstanding outcomes with Catherine in the lower risk residual disease population. There was actually just a real world series that was put together where people had gotten Catherine after having pre-op pertuzumab, and you know the IDFS is like in the 90% range, you know, over 90%. So it's very good. I think the conundrum is, as you point out, people got pre-op T-DXd, where those people obviously were not eligible for DB05. We don't know what to do with them. And, you know, I think the truth is we don't understand, I think what you're alluding to is what is left.
Yeah.
Is it that this person is refractory to T-DXd, and that's why more T-DXd wouldn't make sense? Or is it, we only gave him 4 doses, it's just not enough, right? And what's the biology of that residual tumor, right? And we don't know that. I guess my worry is that if someone got T-DXd THP and they have residual disease, something's funny, right? Because that's pretty potent therapy that we gave them. And if they've got residual tumor, I worry that maybe that's a lot of luminal disease or something that's not so HER2 driven, right? And so I really would want to give someone who had a lot of residual disease further chemotherapy. I would probably give them 4 cycles of AC because I would feel like, hey, they've got residual node positive disease after getting T-DXd THP. I'm going to give a more standard of care chemo because that wasn't sufficient. And then I probably would sequence that with T-DM1, only because at least it's not a cross-resistant payload to, DXd payload. And so that's probably what I would do. But if someone had, to your point, a little bit like an RCB1 kind of amount of residual disease, then I think this question comes up, maybe they just didn't get enough.
Yeah.
The only thing that makes me feel a little funny is that, I don't know how you think about this, but the people in DB11 who got 8 cycles of T-DXd, giving more T-DXd didn't drive up that PCR rate, right? And so, again, this is a different situation we're talking about. It's residual disease, but it does make me wonder if more is the right answer. And I think this is something that needs to be studied, right? We need to figure out what to do.
I think that's why I said, I think all three of us will have a different version of trying to figure out what we could do, because it's such a data-free zone and we really need to address this. Because is it because you need dual HER2 blockade, and even though you have a very potent T-DXd drug, maybe T-DXd plus P is what we needed, so 8 cycles of T-DXd was necessarily not achieving the PCR, but the THP with the T and the P on top of the T-DXd makes a difference. I mean, in practice, let's think about this, right? When we do TCHP and ACTHP, we all have this minor residual disease burden patients, right? Like sometimes we get everything, but not little. We don't give them more THP or ACTHP or TCHP at the back end. But here we're debating that with T-DXd, and we don't necessarily know that yet. So I think one could interpret this so many different ways. We need to address this so much. But I also feel like if I started, say, with THP, if I reverse the order, I did THP, and then I give T-DXd, right? And THP gave me a tumor shrinkage, and I saw T-DXd give me an excellent shrinkage, but then there is still something on MRI or something that we're seeing. Doing more T-DXd in the neoadjuvant, maybe giving 2 additional cycles and then bringing them to PCR or not, could also be something we could do. I don't know if we'll get access to that, but that could be one thing we could have done more upfront.
I think what the problem we're all facing is we don't know the exact number of cycles. And I agree. I mean, I think this is a perfect opportunity for a clinical trial,
right?
For us to really
we're designing one right now
to really study residual disease and try and cater the adjuvant therapy for the biology of the cancer. But I do think there might be scenarios where it may feel like you just didn't give enough T-DXd, and I think those are going to be the patients where you're really paying attention to how they do with T-DXd up front.
Yeah, like do they need THP and maybe a little bit more of T-DXd? You know, I feel like otherwise, like Sarah, I feel more tempted to doing what DB11 did, and in that category where there is residual disease, give more anthracyclines and T-DM1. I think that's what's going to be my approach as well. And then for ER positive, obviously endocrine therapy. I'm just not sure, because we don't know whether this is truly refractory disease or just a few cycles short of T-DXd, until we can tease that out, that I'm comfortable saying that I'm going to do T-DXd again at the back end. And I don't know if this is the right answer or not, but this is what I'm thinking. But I think if we had to give some kind of adoption advice, is there something that either of you can highlight or both of you can highlight? Like, do you think there's, again, going to be differences between what we think about? This is complicated for us when we're thinking about people who are involved in the trials of this. Think about this in the community, right? So is there something that you think from a practical adoption perspective you want to comment on? What would you do with DB11, DB5?
I think it's going to be hard to give one answer for all scenarios. We're really going to have to individualize it. So, and thankfully we've been given such liberal access to these drugs that we will be able to do that to some extent. I think it's certainly something we're going to have to study so that we can have the right answer. But for now, it's probably something which is going to be individualized.
Fantastic. Any practical advice for monitoring for DB5 when it comes to ILD, and how you would think about this, or any advice for our community when they're adopting it? We discussed a little bit about it as to how we would do, but how are you planning your cadence?
I think I'm going to be really sticking to the way they monitored these patients closely on the trial. I really think we can't ever underestimate that risk, and so being super vigilant. It's another reason why I prefer the neoadjuvant approach of DB11, because it is complicated. These are all patients who are going to need radiation. And we don't have an adjudication committee with us. So it's challenging, like you said, to try and tease out what is radiation, what is ILD. And
they're on it for a while.
And they're on it for a while.
And I think the other thing that I think we also realize in clinic is like, we think TDM1 is a well-tolerated drug. We all agree with that, right? Having said that, post-TCHP or ACTHP, doing 14 cycles of TDM1 also is challenging.
Right.
Like, how many patients just don't finish their intended 14 cycles? And I think that's the same challenge we're seeing even now, both with T-DXd and TDM1. So I think that makes it a little tricky, but I think we do our best and patients do their best.
Well, it's interesting, though, because I was actually surprised in DB05 that the number of patients who completed all 14 doses was actually pretty similar.
Between
about
the two.
30% didn't get through all
Yes,
14 of TDM1. They're about 30% didn't get through all 14 of T-DXd. And it's actually what we saw in Catherine, too, with TDM1. It's very similar percentages. So I think you're right that 14 cycles is a long time.
It is.
and it's hard without whatever you're giving them.
Another trial opportunity, guys, here, right? Because maybe we need to figure out, is that, we're doing that in the adjuvant setting, aren't we? We are trying to figure out if we can get away with shorter amount than the whole year. And maybe this would be one thing that maybe we can think about in the adjuvant setting as well. But this was fantastic. I think we cannot end our session without addressing one thing, which is we have this wonderful drug available in every setting, including now in the first-line metastatic setting with DB09.
Right.
And so let's make this situation very complicated. Of course, that's not going to happen tomorrow, but it's coming. We have this early-stage approvals, neoadjuvant, adjuvant. We spoke about how we're thinking about this. And then we have the metastatic setting. How do you think about the continuum of T-DXd, its implications of use in early stage, and then ultimately having recurrence or somebody who has now metastatic disease? How would you think about T-DXd use in that setting? Hopefully, we'll have very few patients in that bucket. I think we're going to see a lot more de novo patients now and not necessarily a whole lot of recurrent. But let's, just for today's theoretical discussion, talk about how are you thinking about that continuum?
Yeah, I mean, we have traditionally been open to reusing a drug, right, that we've used for a fixed number of doses in the early stage setting without evidence of disease progression, again, in the metastatic setting. And you know, it's kind of come about that we've got this magic 12-month interval. And I think probably that's what I will think about as well for patients if they've had a nice interval from their last T-DXd, that I would consider using like a DESTINY-9 approach for first-line metastatic disease. You know, for a patient who relapses very quickly after having that kind of early stage therapy, I mean, it's concerning, obviously, because they've had our best drugs. Again, that's a great population for a clinical trial of novel therapies. But I think if I had to choose something today, I would probably go back to using a Cleopatra type regimen up front in those patients. You know, presumably they will have had 4 cycles of THP in the early stage disease. So, you know, for those patients who are relapsing immediately post T-DXd, look to something unique and different. So Cleopatra.
Okay. Anything to add, Sarah?
No, I totally agree. I think it's all about timing from last dose of T-DXd to make that determination, rightly or wrongly. Again, we just kind of make up these rules. But I think we're going to have to study it. I mean, I will say I agree with you. I think there are going to be very few patients where this, right now, we don't see a lot of recurrences as it is. And so I think with even better therapy in the early stage setting, I'm guessing this is going to be a very small population.
You know, what we might see are patients, unfortunately, who relapse in the CNS. Yeah, right. Who might still relapse with brain metastases. And I think that's going to be the big challenge in the future for patients with HER2-positive metastatic breast cancer.
I mean, we have trials like the residual compass where we have TDM1 plus tucatinib to see if that might change from that approach. Hopefully T-DXd, which has shown such robust activity in brain metastases, we'll see what the impact of that will have in that setting as well. But you're absolutely right. That's still going to be a challenge that we're going to continue to look for in HER2-positive disease.
And hopefully DB05 had a small signal that maybe it's preventing CNS recurrence.
In that highest risk patient population, that will be very intriguing to see what T-DXd offers from early stage for brain mets. We saw 5% with Catherine. Is it better with that? Do we need the tucatinib-like approach with TDM1? Would that be a good strategy as well? So looking forward to that. But listen, this was fantastic. Thank you so much for your insights, for your practical considerations of who you would choose this new way of treating early stage HER2 positive disease, and what kind of things should we still remember when it comes to monitoring and toxicity management for early stage. Thank you for joining today.
Pleasure.
Thank you.